primarily because these are the cancers where we know that there are, excellent tools for us to detect cancer early so that we can therefore get treatment to individuals sooner so that they can live a healthier life and have great outcomes. We do our outreach and education through various materials. We go out to in community settings, health fairs, and so forth. And over the past year, we've had, over 125 unique activities in counties. And as you can see, the vast majority of those counties in our catchment area have had a program or activity, and we've reached over 8,000 individuals. But at the bulk of what we do is trying to, again, bridge that gap and really focus on those medically underserved populations. So we provide education programs to women and men who might be in transition. We also look at individuals and target them if they don't have insurance or have lower socioeconomic status. We do community prevention and so forth. And we do that through lots of partnerships through other clinics and facilities that have sliding fee scales or free services offered. And we're very pleased to know that with our data over the last year, we have increased access to cancer screening. We've really targeted those sites that are served predominantly racial, ethnic minority, and lower income populations, providing PAP and HPV testing, screening, mammograms, diagnostic imaging, fit kits, and informed decision making, and have navigated over 539 individuals. And then lastly, I would say we know that access to clinical trials is a major component to helping people with cancer to have greater survivorship and healthier quality of life. And so part of what we do is to make sure that everyone has access to the wonderful clinical trials that are happening within the Hillman. So we provide targeted education to dispel myths that might be out in the community around clinical trial participation. We walk with patients and provide education and support to help them to reduce their barriers to being able to enroll. And then we stay with them through the process in case there are questions or issues that come up so that we really make sure that everyone does have a fair opportunity to live a long life, even with a cancer diagnosis. So with that, I'll just say that there's been a tremendous amount of progress, particularly in the last 30 years, to reduce cancer disparities, but we know that there's still a distance to go to bridge our gap. And then as individuals, just impart a few things for you to consider. So one is certainly knowing your own personal family history of cancer. We know that a number of cancers have a link to have a higher rate if you have a family member who has that particular cancer. We ask you to keep up with the recommended cancer screening. So they're age appropriate and risk appropriate screenings that we all should be mindful of. I'd also ask for you to advocate not only for yourself, but for others, particularly your loved ones who might not be in a position to speak up if they have a diagnosis or to talk with others about the care that they need. And then certainly learning more about clinical trials, as I mentioned, is really critical for our ability to advance these therapeutics. And then lastly, connecting with local support groups and resources, certainly with us, if you have interest in helping us to bridge that gap. With that, I just say thank you and happy to take any questions.
All right, thanks, Dr. Baskin. I see we had a couple of questions come in through the chat or through the Q&A as you were going. I know we were able to answer them offline. With that being said, we can hop in to our next speaker.
Okay.
And we can come back to you for the full Q&A at the end. Awesome, thank you.
Thank you, Monica. Okay, let's go now to Dr. Jason Luke. He is a practicing oncologist. He's associate professor of medicine in the Division of Hematology and Oncology. He's director of our cancer immunotherapeutics, as well as our early phase clinical trials unit. And we typically think of an oncologist as either a radiation or a medical or a surgical oncologist, but Dr. Luke is one of the folks really leading this fourth modality of cancer immunotherapy. And he'll talk about that and what cancer vaccines and progress that has been observed in the past few years. He received his medical degree at Rosalind Franklin University in Chicago, then went on to receive his medical training at Boston University, followed by fellowships in medicine and medical oncology at Cornell and Memorial Sloan Kettering Cancer Center in New York. He was on the faculty at the University of Chicago, and we were very fortunate to recruit him here, about, I think, 4 years ago. And he's really taken the Cancer Center and the region by storm, opening up new trial opportunities. And one of his real specialties is collaborating with scientists and their innovative ideas and bringing them to patients. I think you'll see some of the advances that he's brought. So, Dr. Luke, we'll turn it over to you.
All right. Well, thank you very much. Just want to make sure that my slides are showing up well for everybody. Make sure they show up at all. Here we go. And if that's not correct, then somebody interrupt me here. So what I'm going to speak on today, and I appreciate everyone taking the time to join us today, is on the concept of cancer vaccines, which have been something that's been of interest for a very long time in cancer, but I think more recently is now starting to be realized due to improved knowledge of how our immune responses against cancer work. So the title here is Cancer Vaccines as the Future of Immuno-Oncology. So as was alluded to, this idea of a fourth modality in treating cancer, it's not an exaggeration to refer to immuno-oncology as a modern revolution in cancer treatment. And we've historically thought of cancer treatment centered on surgery and radiation with attempts to cure the patient, and chemotherapy in the hope that we could try to control it as long as might be possible if we can't otherwise cure it. Immuno-oncology, however, is a different approach, trying to use the patient's own immune system or supplying the immune system such that we might actually be able to get rid of cancer in all of these different phases. And immuno-oncology is now starting to overlap with all these different modalities, and it's a very exciting time. And their major breakthrough for most patients who benefit from immuno-oncology approaches right now is centers on this axis that you see on the right-hand side with this interaction between tumor cells and immune cells called T cells that are attracted to and try to destroy the cancer. And what you can see is this interaction here between the PD-1 and PD-L1 receptor turns out to be dramatically important in a way that I think no one could have possibly understood before this clinical observation was made. So there's science and research that's underpinned this, and I don't have time to go into a lot of it, but I'll note sort of the following to sort of hopefully help you get through it a little bit, which is this idea that whether or not our immune systems have noticed the cancer can make a big difference into whether or not our immune system treatments can be effective. And we think about patients who have had an immune response against the cancer. You can see that on the left-hand side, where we call them T-cell inflamed tumors. And what that means is that the body's host immunity, your natural immune response, has noticed that the cancer is there, and it sent these CD8 T cells that I alluded to before into the cancer to try to kill it. But because the cancer is there and able to fight back, it's able to put these immune cells at bay. But that leads to a triggering of a whole bunch of other biological processes that set up the tumor potentially to be amendable for the use of immunotherapy. Now, unfortunately, many patients do not have this happen. And in fact, the majority of patients, say with breast cancer and prostate cancer, seem to not mount immune responses against their cancer. And what we observe when we look in the cancer is that you don't see these immune cells. And as a consequence, you then don't see these downstream effects. So this is really important because it sets up a paradigm, and we sometimes refer to these tumors as hot tumors because they have the immune cells in them, and these tumors as cold tumors because they lack that immune cell infiltration to drive the explosion of the immune response. And with emerging technologies over the last, say, 10 to 20 years, we've become much more adept at being able to measure the extent to which the immune system is able to penetrate into the tumor. So whereas on the left-hand side, these are one-off tests that help us look at individual proteins, we're now able to use genomic approaches to try to look at which genes are turned on in the cancer. And on the right-hand side is a rather older what we call heat map of different immune molecules. And when we measure them, we can actually identify which tumors have a gene expression profile that's consistent with these tumors that have a high degree of immune cell infiltration. And so why does that matter? Well, it turns out then you can use these data to potentially understand and predict who might benefit and not benefit from immunotherapy. And you can see that on the bottom in what we call Kaplan-Meier survival plots, where we see that the likelihood that the cancer doesn't grow is better. So patients do better over the long haul if they have a high degree of these immune molecules, one of them called interferon gamma, versus the patients who don't have that, who don't do very well. And that's true for this and for how long the patients survive after treatment. So this has become a fundamental underpinning for our ability to understand how these treatments work. And immunotherapy now has become a standard treatment across most of the solid tumor malignancies that we treat in oncology. And I don't have time to go over them all because there's so many of them here, but you can see all across the body, different organ systems with cancer where we use these kinds of treatments. But that's really just the tip of the spear, so to say. Immunotherapy as a concept is actually much broader than this, because immunotherapy could really encompass any part of what we call the cancer immunity cycle, where the cancer starts to grow and can be observed by the body by release of molecules. And these molecules that are picked up by sensing of the immune system can then activate other immune cells to go out and eventually find the cancer and then try to destroy the cancer. And those immunotherapies I just talked about that have been so impressive, they only impact on this step number 7 of enhancing that immune response to kill the cancer once the immune system has already been triggered. So an obvious question then is, how could we improve our ability to trigger the immune system in the first place to actually go after the cancer? And and I guess in that context, it's worth pointing out that this has had a dramatic effect on the survival of patients over a long period of time. On the left-hand side, we see another one of these Kaplan-Meier survival plots where we see all the patients and how long they lived after they developed metastatic cancer, in this case, melanoma cancer. And sadly, about 10 to 15 years ago, the survival of patients before we developed these new immunotherapies on a median or on average was about 9 months. And now with standard immunotherapies that we give in clinic, our 5-year expectation is that more than half of the patients will still be alive despite the fact that the cancer spread in their body. Again, emphasizing that it's probably the case that we can cure some patients, even with metastatic cancer, with this immunotherapy. As a contrast, however, though, you'll observe that about half of the patients are not cured yet with the immunotherapy. And that's where our aspirations lie, to try to improve this process to benefit more people. And in that regard, then, we've started to become enhance our understanding of what does the immune system actually observe when the cancer is present. And in fact, it's this concept known as a neoantigen, and it goes back to the DNA of the patient and the cancer, such that under a wild type setting or normal setting in a patient, you have the normal DNA, which gets transcribed into a protein, and your body is primed not to generate immune responses against the normal DNA and proteins in your body. Because obviously, if it did, your body would be attacking itself all the time. And rather, when cancer develops, what can be observed by the immune system are these changes in the DNA in the cancer itself, because those then get translated eventually into abnormal proteins. And these neoantigens can actually be observed on the surface of a cancer by the immune cells that are passing by and trigger those responses to the cancer. So we now know that immunotherapy correlates clearly in terms of improved outcomes with the presence of these neoantigens. And you see on the left a plot that shows the number of mutations present across various different cancer types, with whether or not they have a high, moderate, or low level of these neoantigens. And you'll also observe quickly that these neoantigens are associated with cancers that are driven by the presence of carcinogens. So whether smoking or sun exposure and so on and so forth, because those exposures can lead to damage of the DNA and abnormal presentation of those proteins. And in fact, when we observe the outcomes or response rate to immunotherapy, the tumor types that have the most of these neoantigens are those that benefit the most from the immunotherapy. So as we think about that then, and go back to our cancer immunity cycle, we might be able to further enhance the treatment by increasing the number of tumors that can be observed by the immune system on first principles. And we might be able to do that by using the neoantigens that are released from these tumors. And that leads us then to this. which is this recent news about neoantigen vaccines that they've penetrated through even to the lay media. And this is quite a complicated process, but briefly, we can take the tumor and match it against the patient's normal blood and see what the differences are in terms of the DNA between the normal and the abnormal cancer. We can then use that information to generate vaccines that have nucleic acid sequences that harbor those differences that are present only in the cancer. And you probably all actually know about this already in the context of COVID, because mRNA vaccines encoding the virus have obviously what saved us all from COVID. And the concept here is very similar. We can take the abnormal nucleic acid sequences from the cancer, put them in an mRNA vaccine, and then come back and vaccinate the patient so that they now will recognize these abnormal sequences. And the immune system then is primed to go out and look for those abnormal sequences, which are going to be in the presence of the tumor. And as I mentioned, this has penetrated into the lay press, where the company Moderna announced the results of a clinical trial where we combined, after surgery, an mRNA neoantigen vaccine with the standard immunotherapy that we would normally give. And this led to a substantial benefit more than just giving the immunotherapy alone. And this is the press release. And on the right-hand side was a Washington Post article for which I was interviewed for. Because here at the University of Pittsburgh and UPMC, we have been one of the leading sites providing this treatment and leading this kind of research across the world. And in fact, now a definitive clinical trial that may lead, and hopefully will lead to registration and standard treatment using these mRNA neoantigen vaccines is now being launched across the United States, Europe, and the rest of the world, with UPMC and UPitt being one of the leading drivers of this clinical trial. So with that, I'm going to pass. I'm going to hold off. I'm sure there could be many questions. I just always try to leave with sort of something funny. Here's this cartoon with a dendritic cell, which is the cell that senses these abnormal nucleic acids, talking to one of the killer T cells and saying, here, T cell, here's a fragment of the intruder. So go find it and get rid of it. And conceptually, that's what we're trying to accomplish with these cancer vaccines. So thank you very much.
Awesome. Thank you, Dr. Luke. Looks like we did have a couple questions come in as well, and there is one in the chat. You should be able to see. You mentioned breast cancer. Immunotherapy might not always work. Just looking to touch more on that, and if there's like different types of therapies for all cancers, and just kind of how that part works.
Right. So there's absolutely different kinds of treatments for different cancers. Some kinds of breast cancer do respond well to immunotherapy. The triple negative breast cancers fall in that regard. In the hormone or HER2-driven breast cancers, to date, immunotherapy has been less effective. And we think one of the reasons is because those breast cancer subtypes have fewer of those neoantigens that I just referred to. But now that we have this technology that I alluded to, I think it's very reasonable to think that it could be a future where we do prime the immune system with the patient's specific neoantigens, and we might be able to improve immunotherapy outcomes in all of breast cancer, albeit that that's still waiting to be seen. I see another question pop up about pancreatic cancer, and the answer there is functionally the same. These kinds of approaches are being applied in pancreatic cancer, but they're in the research realm still and have not yet become the normal treatment that patients would receive.
All right, great. And then it looks like we have one more that came up in the Q&A from an anonymous attendee. I'll read the question out loud. It says, my son has colon cancer stage 4, originated from BRAF mutation. So is this mutation hereditary? And if so, we have been told blood testing can detect the presence of that mutation. Is this also correct? And who needs to undergo the blood testing?
Right. So I see the question, and I guess it's important to point out that in a venue like this, it's probably not the best to give medical advice because we don't have all of the information. But what I would suggest is that BRAF mutation in colon cancer is not, generally speaking, hereditary. In fact, it's not hereditary at all as far as I know. So when people are diagnosed with cancer and are particularly young, it is often recommended to undergo genetic testing because there could be a reason, but BRAF itself would not usually be the reason why. But I think that emphasizes why it would probably be better for the specific doctor associated with that patient's care to discuss that, because there may be further extenuating circumstances.
Great. And I think before we get to our next speaker, I know we have a couple more in the Q&A, but there's just one more in the chat, and that'll be the last one before we get to our next speaker. Just question about prostate cancer that is metastasized.
Sorry, where's the question?
Just in the chat.
Prostate cancer has metastasized.
Mhm.
I guess I'm not sure what the context is for the question. Certainly, there are many treatments for prostate cancer that are standard treatments. In terms of immunotherapy, we are working on how to improve the results of immunotherapy, both with the kind of approaches that I'm mentioning, as well as another class known as adoptive cellular transfer, but that's kind of out of the scope here. Suffice it to say, there's a lot of treatments that are trying to be developed for prostate cancer.
Right.
Jason, another question. Does irradiation of tumors increase the frequency of neoantigens?
I saw that, and there are some more questions. I'm happy to respond to them. The answer to that is maybe. It likely is the case that some neoantigens are released because radiation will basically blow up the tumor and therefore release some of the particles of the tumor, and those particles might be seen by the immune cells. So, that hasn't been fully established yet. It's thought that that could be the case. Whether or not that's equivalent to making a full vaccine, I think that's unknown. But we continue to study issues in that realm.
All right, great. Thank you very much, Dr. Luke. And we'll pass things back off to Dr. Ferris, introduce our final speaker, and then again, we will have time at the end to go over any unanswered questions, and then time for more questions.
Exactly. And I hope you'll see from the two speakers already and our third faculty member, the breadth of activities and the really exciting aspects of research and patient care. And so one of our newer recruits, Dr. Catherine Schmitz, Katie comes to us from Penn State Cancer Center, and she is a leading expert in a field that she had to teach me about a little bit called exercise oncology. There were two words I knew what they each meant, but I hadn't exactly seen them put together. I think as you'll see, her passion and her expertise is in using exercise in the roles of cancer prevention, control, and survivorship. And she's been setting up since the fall a leading exercise oncology program with physical space in the cancer center, building connections out into our large cancer network of the Hillman Cancer Center around Western and Central PA. She will discuss some of the clinical trials and the benefits of exercise for oncology patients. She's got 4 NIH grants. I'm happy if I can even get one. So she's highly funded and is also a recipient of a prestigious American Cancer Society Clinical Research Professor Award. She's past president of the American Society for Sports Medicine. Dr. Schmitz, it's all yours.
Thank you very much. As I like to say, my mother would have really liked that introduction, so I appreciate it. So I'm going to share my screen, and I'm hoping somebody will tell me if that is not showing up the way that we want it to. As was the case for Dr. Luke, you can find me on Twitter at FitAfterCancer. He showed his Twitter information as well. So I do want to start with just introducing the field of exercise oncology to this audience. So this slide shows the trajectory of the field of exercise oncology focused on human clinical trials since 1990. And I can actually go back farther than that. There were studies that were done in the 1940s at the Wistar Institute in Philadelphia. And it must have been an exciting time in that lab. They had rats swimming in a barrel, and they expected that the tumors that they had inserted into those rats would grow more quickly as a result of the stress of the exercise. And imagine how surprising it was in that lab when they figured out that it was quite the opposite, that the exercise actually slowed the growth of the tumors in the animals. The first human clinical trials in the area of exercise oncology were performed in the late 1980s. And I published the first meta-analysis that brought together all of the data in the field, 22 clinical trials in 2005. I am the mover and shaker behind the American College of Sports Medicine guidelines for exercise for people living with and beyond cancer. We held our first roundtable in 2009, published it in 2010. And at that point, there were about 225 trials. And by the time we did our second roundtable in 2018, the number of clinical trials in the field of exercise and cancer had grown exponentially by 281%. And even today, if you were to search the library that scientists use to find each other's work, called PubMed, it's shown on this slide, PubMed. You can go Google it yourself right now and put in terms like pancreatic cancer and immunotherapy, things like that, if you're interested in learning more, and you'll get the scientific evidence base. So if we were to do that right now, what we would find is that there are 2,600 randomized controlled trials that are in PubMed about exercise and cancer. So this is not something that I came up with this weekend in my garage. This is clearly a field that has come into its own during my career. So there are a few things that we feel that we can really say. There are a few outcomes for which we feel we have sufficient evidence that there is kind of a canon, and what we say is very clear benefit of exercise during and after cancer treatment. Cancer-related fatigue is at the top of this list, and I would submit to you that the National Comprehensive Cancer Network, which guides how medical oncologists should treat your cancer, recommends exercise or physical activity as the #1 treatment for cancer-related fatigue. It's a little, difficult to understand because you're tired, and so why would you go for a walk in order to help your fatigue? But indeed, that is the very best thing that you could do for cancer-related fatigue. We also know that it improves sleep, quality of life, anxiety and depression, body composition, physical function, which is to say your ability to carry a bag of groceries, to get on the floor and play with your grandchildren, to climb a couple of flights of stairs, to walk through an airport in order to go see a family member. And we know that it improves breast cancer-related lymphedema as well. There are obviously other outcomes that are under study at this time. I have funded work to try to look at some of the other outcomes as well, but these are the things that we can hang our hats on, if you will. And so guidelines around this have proliferated. I have mentioned that I was behind the American College of Sports Medicine guidelines. This is the major paper that came out in 2019 from ACSM. But in addition to ACSM, the American Cancer Society has spoken on this issue as well. They published their guidelines in 2022. And very importantly, the American Society of Clinical Oncology, which is the professional organization for medical oncologists in the United States and a major player in the field, very important voice in the field, put forward a guideline in May of 2022 that used strong language and said that we should be using exercise in the setting of medical oncology in order for patients to address common symptoms and side effects. So this is a summary of what those guidelines say. The American College of Sports Medicine is, the exercise physiologists, and so we're going to be probably the most specific and prescriptive of the exercise guidelines, and so we are. The recommendations during treatment are that patients get 3 times a week, 30 minutes of moderate intensity aerobic activity, that can be walking, and twice weekly resistance exercise. After treatment is complete, it is recommended that the amount of exercise increase, because we know that from epidemiologic evidence that higher amount of exercise is associated with reduced risk of cancer-specific mortality for breast, colon, and prostate cancer. We also recommend twice weekly resistance training in order to regain and maintain function as we age after cancer. The American Cancer Society does not make any specific recommendation for the dose of exercise that is recommended during treatment, nor does ASCO, but both of them recommend that people should be exercising during cancer treatment. ACS agrees with the American College of Sports Medicine about the aerobic exercise in the post-treatment timeframe. So why don't we just sort of give people a handout? Let's just do that. Why wouldn't we just do that? Let's just give people a handout and say, you should go exercise. Well, it turns out that brochure therapy doesn't really work. And so I would submit to you a thought exercise. So just go on this thought exercise with me. I'm not suggesting that we actually do this, but I want to point out the infrastructure that surrounds chemotherapy and how we treat with immunotherapy or chemotherapy. as compared to what currently exists for exercise oncology. So if we treated chemotherapy the way that we treat exercise at present, we would do something like this. We would say, the medical oncologist would say, well, there's evidence that chemo might help you. Here's a handout about it. You can call the YMCA and see if there are classes starting soon. If not, you can wait 12 weeks. The classes are only offered on Tuesdays at 7 p.m., so I hope that works for you. You can see that that would create access problems. People would have difficulty with transportation. There's very little help. They'd have to figure out an awful lot on their own, just like they have to figure out physical activity on their own. Or it could be that they would say, we'd like you to get some chemo. It's been shown to improve survival in people with your type of cancer. The handout will explain what to do. So you can imagine that chemotherapy would happen much less often if we were to treat it this way. So this is just a thought exercise to point out that people probably do need more support than a brochure in order to support them getting adequate physical activity during and after their cancer treatment. I'm very proud that over the past 2 years, I have been a leader with the National Accreditation Program for Breast Centers standards revision process. And I'm extremely proud of this new language for the medical oncology standard. And what I'll point out to you is that now there is a recommendation, or not even a recommendation, but a requirement that medical oncologists make exercise therapy recommendations. And this will go into effect for all breast cancer patients receiving medical oncology care as of 2024. And just to give you an idea, a recently published survey from the American Society of Clinical Oncology indicated that only 15% of cancer patients were referred to exercise during their cancer therapy. So we have a ways to go in increasing the number of referrals to exercise therapies. So the big question then, if we have this evidence base, and I'm going to ask you to go with me on the journey to say that we should be doing exercise during and after cancer treatment. How do we do this? This is Tomorrowland, right? This is how do we translate from our current state to Tomorrowland? This is called implementation science or health services research. So what we're doing at UPMC is called the Moving Through Cancer program. This is the website for the Moving Through Cancer program. We do have a physical footprint on the second floor of Hillman Cancer Center. There is a small gym now that is just outside the waiting room on the second floor of Hillman Cancer Center. What we're doing is a kind of a triage process. We are in the process of identifying people at the second chemotherapy visit, where we apply a triage tool that is a validated instrument. We're asking about physical function issues, whether people have fallen recently, whether they have a lot of pain or fatigue. Then we're giving patient counseling, and we offer programming that is appropriate. This is a program that is for everyone. No one here is being asked to do a clean and jerk. No one here is being asked to do CrossFit or run a marathon or bicycle 100 miles. And we're trying to meet people where they are, and it might be chair exercise for some people. It might be physical therapy for some people. We're then trying to connect people and making a warm handoff, making it easy for the clinicians who are treating these patients to connect people to appropriate programming. So far, what we have found in the first 5 weeks of running this program is that 26% of the patients that we have triaged are referred to community programming. And so we can refer those folks to the UPMC Prescription for Wellness program or to community programs like Caring Bridge. 35% of patients are being referred into the individualized exercise programming with our Moving Through Cancer staff on the second floor of Hillman and using that gym. And 39% of the patients that we have triaged so far would benefit from some kind of rehabilitation services, would benefit from a physical therapist's care because they have some kind of impairment that is interfering with their ability to function in their day-to-day life. So our overall programmatic and research goals with the Moving Through Cancer program are to increase the proportion of chemotherapy patients connected with triage outcome appropriate exercise programming to 50% or more. We have gotten to 37% in 5 weeks. And so we are working on trying to improve that all the way up to 50%. And we'd like to assess the effects of this program on chemotherapy tolerance, on unplanned hospitalizations, which cost a lot of money and are a very important cost in the cost of cancer care, We're interested in cost overall, the cost of running the program as well, and patient satisfaction. So I will finish there and let you know that I am immensely grateful for the opportunity to tell you a little bit about what I think about all the time. And I hope you'll have some questions for me. Thank you.
Awesome. Thank you very much, Dr. Schmitz. With that being said, we do have a question that came in for you. I do want to let everybody know that we do have about 15 minutes for questions for all of our panelists, all of our doctors. So if you have any extra questions you'd like to ask, we can invite everybody back at this time for some Q&A. But the one for you right now, Dr. Schmitz, what do you recommend for those 5+ years out of chemo treatment, more or less in the guidelines in the post slide that you showed?
The recommendation 5 years out would be 150 to 300 minutes a week of moderate intensity aerobic activity. That could be brisk walking, and twice weekly resistance training. And if you need some assistance with getting that going, let us know.
Mm-hmm. All right, great. Thanks. So while we wait for some other questions to come in, again, we want to use this as an opportunity to invite everybody back. We do want to give a quick plug. I think, Dr. Ferris, you can talk more about our Rush to Crush Cancer event coming up. So while everybody's typing in their events, I'll turn that over to you to give a quick plug real quick.
Thank you, Tyler. Actually, it's perfectly timed with Dr. Schmitz's presentation. At the Cancer Center, we've had an annual gala for 20+ years. It was a lot of fun, but it was pretty narrow. It was a few hours, one evening, once a year, and it was a good opportunity to thank and celebrate progress in cancer research and advances in cancer treatment. But it felt a little bit elitist to us, and it wasn't as community-oriented as we wanted to be. And it honestly didn't actually raise all that much money. And so we've evolved now into a new event that starts May 20th, 2023. So about 5 weeks away. We call it Rush to Crush Cancer. There will be 3 rides. It's not a race. It's a ride. There's 15 miles, 40 miles, and 60 miles for the real riders out there. And there is a survivor walk. And so we invite everybody to participate. It is got a few different courses around town. We've set up a separate organization with staff. And the goal of this is to increase our exposure to our community, our constituents, our citizens, create opportunities for education around prevention, early detection, and of course, exercise. And it ties in nicely with the comment somebody put about James Conner, and it's public, so I'm not divulging anything, but I actually helped diagnose him, and he's been a tremendous advocate for the Hillman Cancer Center. And you're absolutely right. His fitness and his commitment to education of cancer and his physical status helped him to endure a difficult cancer treatment by my colleague Stan Marks, and he comes back and helps us a lot. And of course, we may not all have the muscle mass of a James Conner or other athletes, but we can get out on our bikes for Rush to Crush and ride as much as you want, or you can come volunteer and you can sponsor any of our riders. We've got, I think right now, 400 or 500 registrants. So May 20th, 2023, it's the first event of what will be annual. And I think it will help us to fund much of the work that you heard about today from these 3 fantastic faculty. And we actually have over 300 Hillman Cancer Center investigators, scientists doing similarly exciting work that would benefit from this kind of support that Rush to Crush and other donations help us to build and support. So just wanted to put that out there, and we can provide more information to those who might want to participate. But you can also Google rushtocrush.org.
All right. Awesome. Thank you very much for that, Dr. Ferris. And I hope anybody who would like to participate will. That being said, we do have some questions coming in at this time. So I will let our presenters, our doctors volunteer which questions they would like to answer. I see Dr. Baskin is answering one already. Dr. Baskin, you're welcome to address it live if you would like, or you can also type in your answers. So I guess if you'd like to start with that, the question is, how do these new programs, research projects get funded? And has inflation, COVID, other economic considerations impacted grant availability?
Great. Thanks so much, Tyler. And I'm here, just not on video. So would love to answer that. And I think it actually, dovetails nicely with Dr. Ferris was just talking about. So one of the ways that we can fund our programs and our programmatic services that are not tied to research is certainly through the generosity of donors. So various events that we have, like Rush to Crush or any other kinds of donations that come in, oftentimes go to our prevention and cancer screening activity. So many of those people that I mentioned that we navigate for free or low cost screening are because we hit those unrestricted dollars to be able to help them with that. In addition to that, certainly our major source of funding for our research projects typically comes from the National Institutes of Health and specifically the National Cancer Institute. There are other federal sources like the Center for Disease Control and Prevention and the Department of Defense and USDA. So we get a lot of funding for that. And so the other part of the question has, have we run into some challenges with economic considerations? I think the answer is yes. There are more people applying for grants than there is money to distribute out there. So that gets much more competitive, especially around cancer research. So I think certainly if you or someone who has been blessed with resources that they can donate and give to us to do more of that work, that's fantastic. And then also if you are so inclined to reach out to your policymakers and really talk about how funding for our cancer center is really important to getting those new discoveries, but also to provide access to care to everyone.
All right, great. Thank you for that. And for our attendees watching, listening, you can see that our presenters are answering some of your questions through text too. So you can see in the Q&A box text answers to your questions. We're going to try to get through as many as we can. We might have a few unanswered and we can try to follow up with this afterwards. But I see Dr. Ferris would like to answer one live. The question is there a website that we might be able to see related recruiting clinical trials that are now being run by each physician?
Yes, I was going to try to find the link, but you can Google in Hillman Cancer Center research. That will go right to our website where there's a tab for clinical trials. We also developed an iPhone app, so you can go to the iTunes store and search Hillman Trials Finder. It was a little bit buggy, so we're working on it to be sure that it gets the most updated trials. But you can search by disease type or disease stage or even by doctor and pull that up. And so we're trying to kind of get that a little bit more real time as trials open and close. But for sure, our website links directly to the clinical trials, and we have at any one time 400 to 500 clinical trials. Some of them therapeutic, others we call biobehavioral, like exercise interventions or palliative care, et cetera.
All right, great, thanks. And I know we're getting through some other questions here. Dr. Luke, let's see, I think you just answered one, so we'll see what's the things that are popping up over here. Dr. Schmitz, if you would like to respond, I see you asking about traditional cancer. TX has not been in past included in specific exercise programs. So the question is, after treatment, any nutrition-based recommendations for specific cancers? If you'd like to answer that one live.
Right. So I actually wanted to answer this live because I have to say something that's not very, you're not going to like what I have to say, and I didn't want to type it. During cancer treatment, the American Society of Clinical Oncology has done a review of exercise as a potential therapy, nutrition as a potential therapy, and weight loss as a potential therapy for symptoms and side effects during cancer treatment. And their conclusion, based on an expert panel review, is that it is only exercise that shows evidence of benefit during cancer treatment. Now, after cancer treatment, we have evidence that nutrition becomes more important in epidemiologic literature in looking at prevention of cancer recurrence and cancer mortality. And in that case, I refer you to an outstanding set of websites that the one that I would refer to most would be the American Institute for Cancer Research. It's connected to the World Cancer Research Fund, and Dr. Baskin leads committees for what's called the Continuous Update Project for this organization. And they do remarkable reviews and give really outstanding lay summary-based information about what you should be doing in order to reduce your risk of a cancer returning or of death from a cancer returning.
All right, great. Thank you for the help. And thank you for everybody that's answering the questions as we go. Before we wrap things up, I'm going to launch just a really quick just survey poll. So for everybody that's attending, we would just like to know what you thought of this webinar. If you'd like to pass it along to any friends. And I also want to follow up with everybody that I will send out the recording to this webinar. So you can rewatch, you can share with any friends. And also I'll share the questions and the answers that came through and that our doctors answered over here. And I know the last question that kind of came through, and we can include this as well, was just any resources, websites. So in the follow-up, I'll try to include any links or any helpful resources. So for all of our doctors here, if you want to provide that with me, I can provide with our guests any of those helpful resources, websites that you shared, as well as any different pages. I know some of you shared like your Twitter as well. So any kind of contact information we can include in that. And that being said, I just want to make sure, see if we have any other questions before things come up here. And let's see, Rebecca dropped something. If any other questions come up, we can always reach out to the Hillman Cancer Center Development Office to get involved. So she's dropped her contact in there. So I hope this has been helpful to everybody. And I think we are almost out of time here. So I think we were able to get through all of our questions. But again, thank you to all of our presenters for being here. Thank you, Dr. Ferris, for moderating this. And thank you to all of our guests for attending today. Like I said, I will follow up and hopefully you'll join us for more future webinars and other programs that we may have as well.
Thank you, Tyler. Great job. Thanks, everyone.
Sounds good. Have a good one, everybody. And thanks for coming.